maybe I'm wrong, but it kills me some of this stuff about schools and people are like having welcome breakfast and they're inviting the class, and I go,
Yeah. All the fun.
I shake my head. I mean, my son graduated this year, and it hurt my heart for him not to participate in things. But I was like, we have a executive order, and so should we not be listening to that?
Yeah. Yeah.
Day in the life of Dr. Marilyn Pearson, right?
Yeah.
Yes. And Dr. Eugene Maynard, who
And
is
Dr.
my,
Maynard, too.
he's the chair of my board.
Good evening, and welcome to the second in a continuing series of community discussions sponsored by the Black History Committee of the Johnston County Heritage Center. My name is Denise Joyner Bennett, and on behalf of the Black History Committee, we're very excited that you've joined us this evening. Tonight, our esteemed panel of community leaders will discuss the topic, the right to live, re-examining racism. Their focus this evening will be on the COVID-19 virus and the physiological effects of racism and discrimination on health. A common theme of these communities' discussions is looking at the major systems in our county through the lens of systemic racism and discrimination. Now, our first program was back in February, just a few weeks before the coronavirus hit, and it was called The Fight to Vote. The speaker from that presentation was from Common Cause, North Carolina, and he gave us a historical perspective of the continuing fight for suffrage in the nation in general and North Carolina specifically. Our second program tonight is The Right to Live, and we'll be looking at health care, specifically the COVID-19 virus. Now, in ensuing discussions, we will be looking at the criminal justice system, the right to breathe. That presentation will be September 10th at 7:00 p.m. And then our fourth in our series will be the right to learn, looking at systemic racism in our educational system, and that will be October 8th. We hope you'll be able to join us. Now, our moderator for the evening is Dr. Twyla Wells. She is Vice President of Advancement and Community Relations at Johnston Community College. Following a brief historical background of racism and healthcare in Johnston County by the director of the Johnston County Heritage Center, Todd Johnston, Dr. Wells will come and introduce our panel and begin our discussion for the evening. Todd?
Good evening. A recent report of the American Medical Association pointed out that in order for leaders in healthcare professions to make the best decisions regarding racial disparities, they first need to understand, acknowledge, and learn from events in the past. I could not agree more. So if you will indulge me for just a few minutes, and I mean a few minutes, I would like to give you a little historical background before we hear from our panelists. Enslaved Africans, Native Americans, and Europeans all used roots and herbs to treat the sick in the early period of our country. This was by necessity because there were few doctors. Even when professional physicians increased in numbers in the late 19th century, herbal medicine and home remedies were so ingrained in the culture that calling a doctor was a last resort. In the first few decades after emancipation in 1865, medical reports show there was a marked increase in the number of cases of tuberculosis, also called consumption, and higher rate of disease and death in general among African Americans. Since freedmen did not receive the 40 acres and a mule that they had been promised, most were forced into an oppressive sharecropping system in which landlords and merchants demanded that they invest their time and energy in cash crops. Some poor whites also fell into this trap. Food crops were neglected, and diets and health suffered as many people subsisted on fatback, molasses, and cornbread. They drank water from open wells that could easily be contaminated by birds and insects. As racial segregation became institutionalized, it was uncommon for white doctors to go into black homes. To fill the need for black doctors, missionary organizations built universities for freedmen and started medical schools, such as Leonard Medical School at Shaw University in Raleigh. At first, the faculty was all white. Well-trained black doctors graduated only to find themselves barred from membership in the American Medical Association and in state and local societies simply because of the color of their skin. Black doctors formed their own societies while still seeking medical advice from and giving advice to their white counterparts who greatly outnumbered them. Over 400 black physicians were trained at Leonard in Raleigh between 1881 and 1919 when the school closed. There were 2 Johnston County natives who received medical degrees there around the turn of the century, but both chose to practice elsewhere, one in Wilson County, one in Edenton. It was not until 1912 that Johnston County had its first credentialed African-American physician, but he stayed only a short time before returning to Raleigh. In 1916, a young physician from the British West Indies had just graduated from Leonard and had heard about the shortage of black doctors in eastern North Carolina. He was headed to Dunn in hopes of hanging his shingle there. An ice storm delayed him at the train station in Selma, and he decided to stay there. A year later, he moved to Smithfield and opened an office in a black-owned commercial building at the corner of 3rd and Market Streets, right across the street from the location of the Heritage Center today. Until the 1960s, he would be the only African-American physician in this county. His name was Charles W. Furlong. Dr. Furlong's mother was a healer in Antigua and Trinidad, and it was her work with herbal remedies that inspired him to go into medicine. A few years after Dr. Furlong arrived in Smithfield, a small hospital for whites was opened in 1920. Then a privately owned county hospital was built in 1926. It had a colored ward, which included 3 rooms accessible through a back entrance. From a racial standpoint, it was separate and certainly not equal. And Dr. Furlong did not have privileges to treat patients there. It was no coincidence that 3 years later, Dr. Furlong built his own small hospital across town. It had 12 beds, later 15, an operating room, living quarters for nurses, dining and kitchen facilities, and an office. Local black teachers and students and black church groups raised money to help with the furnishings. Dr. Furlong performed routine procedures in his OR. He trained midwives and delivered countless babies in his hospital and in private homes. He gave physical examinations and vaccinations to school children. For serious illnesses, he would send patients to hospitals in Raleigh and Durham. He eventually had a wife and 2 children and built an attractive Tudor-style home on South 5th Street. He's remembered as an avid tennis player and built his own tennis court near his home. He was also a lover of wrestling matches, I understand, and new Buick automobiles. More importantly, he was a mentor and a counselor to generations of young African Americans, many of whom pursued careers in healthcare. It was simply impossible for one physician to serve every African American in Johnston County, so black patients relied on assistance from midwives during childbirth and on white physicians such as Dr. G.A. McLemore of Smithfield. Dr. Mack is remembered as the only white physician in town who would make house calls to black homes. People, regardless of race, also knew that they could show up on his porch just down the street from Dr. Furlong on South 5th Street and get sewn up or doctored. In the days before ambulance services, he would drive the seriously ill to Raleigh hospitals in his own personal vehicle. Following World War II, an effort mounted for a modern hospital in Johnston County. In 1951, Johnston Memorial opened with facilities and services for African Americans that were touted as separate but equal. The second floor was for black patients and was staffed with black nurses. There were separate waiting rooms, restrooms, labor and delivery rooms, newborn nurseries, and dining rooms. Black nurses could not dine in the cafeteria, so they took meals in the small lounge where orderlies and housekeepers ate. The operating room was the only space not segregated by race. The blood bank was segregated only by blood type, not by race of the donor. Dr. Furlong was given hospital privileges at JMH, so he eventually closed his hospital, lovingly known as Dr. Furlong's Hospital. In the late 1960s, public schools were integrated, and soon the hospital gradually integrated as well. As time progressed, Johnston County welcomed more black healthcare professionals. However, racial disparities still persist to this day, and that is why we're gathered for this conversation tonight. So without further ado, I will turn the platform over to our moderator, Dr. Wells.
Thank you, Todd. Welcome, everyone, and this is a great evening to be together for the Right to Live, re-examining racism. I'd like to start off tonight by introducing our panelists. Dr. Geddes Cohen Jr., a native of Spartanburg, South Carolina, worked as a dentist for over 45 years serving in the U.S. Navy. He married the former Shirley O'Neill of Selma, and they have 2 adult sons and 5 grandchildren. He received his dental degree at Howard University and then served as an assistant professor at Howard School of Dentistry. He also did private practice in Washington, D.C. before relocating to his wife's native Johnston County, and he opened a dental practice in partnership with the late Dr. Willard A. Smith in 1976. Dr. Cohen and Dr. Smith were the first African-American dentists to open an evening practice in Johnston County. He's an active member of St. John AME Church in Selma and currently serves as president of the Johnston County branch of the NAACP. Welcome, Dr. Cohen. Dr. Eugene Maynard has practiced family medicine in rural Johnston County for 24 years. Born and raised in Apex, North Carolina, he received his medical degree from UNC Chapel Hill. We're not going to hold that against you. I'm a Pack fan. And completed a family residency at Washington Hospital in Washington, Pennsylvania. He currently serves as medical director at Benson Health, chairman of the Johnston County Board of Health, and on the board of managers for UNC Health Alliance and UNC Senior Alliance. In collaboration with the North Carolina Farm Workers Program Project and the North Carolina Farm Worker Health Program, he has operated a migrant farm worker clinic at Benson Health each year for the last 14 years. Welcome, Dr. Maynard.
Thank you.
Next up is Mr. Frederick D. Nelson, Jr. He currently serves as town manager for the town of Benson, having served on the town board from 1997 to 2017, and 10 of those years as mayor pro tem. A graduate of Fayetteville State University, Mr. Nelson's career is in the field of mental health, and it spanned over 35 years in various roles. Mr. Nelson lives in Benson with his wife Hazel, and they have 4 children and 9 grandchildren, and he serves as a deacon at St. Mark Christian Church in Dunn. Welcome, Mr. Nelson.
Thank you.
Last up, Dr. Marilyn Pearson. She's the public health director for Johnston County. Busy lady these days, very busy. She received her Bachelor of Science degree from Clemson University and her MD from the University of North Carolina at Chapel Hill. She completed her internship and residency in family medicine at Carolina's Medical Center in Charlotte, North Carolina. After 7 years as a physician in the Johnston County Health Department clinics, she became health director and medical director, directly supervising 3 physicians, 6 physician extenders, and other managerial support teams. Dr. Pearson is married to James McLean, a chemist, and they have 2 children. Welcome, Dr. Pearson.
Thank you.
All right, so we're going to kick off the portion where we get to get the input from your perspectives and really delve deeply into the healthcare issue and how it is in the context of racism. This will be for all panelists. I'll start out with Mr. Nelson. What evidence of racism in the current healthcare system have you witnessed personally?
Thank you, Dr. Wells. My hope as I share this story with you all is that these days, this experience that I went through some time ago does not happen. I had to wait an extended period of time to be seen by a physician who was assigned to my case. And for me, that case was emergent and urgent. I waited in the triage room some 1 hour. My family will tell you that I have a long history of being very patient. But at this time, as I look back on it, I think I was a bit too patient as I exited that triage room and went to the counter to speak with the administrative staff there. I was ignored by, at that time I did not know, my physician who stood within arm's reach of me. I arranged for another appointment, and needless to say, I asked for another provider. The white gentleman who was assigned to me never acknowledged, never apologized, never asked the question why I had to wait so long. My hope is that these days that does not happen to my contemporaries. I would also like to speak a little bit to what I experienced in my work as a mental health professional, where I saw that the frontline staff at various agencies where I worked were in the numbers from 80 to 90% of Latin American or African American folks. The upper level management of those agencies, God bless you, were at best 5 to 10%, of whom we hardly ever saw. That same demographic in one agency where I worked was not represented at all. So I think that there is some opportunity missing there when people of color are not represented as members of healthcare provider staff. And I can speak to that a bit more as we speak to the next questions. Thank you.
Thank you, Mr. Nelson. How about you, Dr. Maynard, if you'd like to take your position on that, please.
So as a physician here in the county for 24 years, I've definitely seen some evidence for explicit racism. As a medical director, I've had a provider basically refuse to see Hispanic patients. And that provider basically told me that those weren't people that she wanted to take care of. That was very alarming to me. There also have been a number of cases where patients have declined to see African American physicians that were in our practice. And that is always a difficult issue as well. I think, though, more often the racism comes in the form of implicit bias. We know about terrible things like the Tuskegee syphilis study and forced sterilizations that occurred in the past, but even since I've been in medicine, there's so many different forms of evidence that racism is still alive and well, unfortunately. Back in 2000, there was a study that showed that African Americans who had long bone fractures were much less likely to be treated with pain medication than white folks who had the same exact presentation and fracture. And even back in 2016, just 4 years ago, a study was done, and half of students and residents in U.S. medical, who are associated with U.S. medical schools, felt that African Americans had thicker skin and fewer sensory nerves, so that they felt pain less, which sort of explains the previous study. But that was only 4 years ago. And even now, there is so much evidence of inequity. African Americans are much less likely to have colorectal cancer screening. They're much less likely to be recommended to have a cardiac cath or coronary artery bypass surgery, even with the same presentation as white patients. They're much less likely to get an insulin pump if they have type 1 diabetes. They're much less likely to get an implantable defibrillator. They're much less likely to get prescribed newer medications that are on the market. And all of these are studies that have come out in the last 2 or 3 years. So clearly, there's a problem. There are definitely some systemic issues. One of the biggest, which Mr. Nelson mentioned already, only 5% of doctors in the U.S. are African American. Only 5.8% are Hispanic. And unfortunately, we're not really on a track to improve that, because last year, of the medical graduates who graduated in 2019, only 6% were African American. Only 5.3% were Hispanic. And African Americans have the lowest acceptance rates of any group applying to medical school. And that was as recently as last year. There are also a number of issues that have recently come under more scrutiny. There are a number of race-based guidelines and standards in medicine. One is a a guideline that we use to determine which blood pressure medications we use. There's actually a step in there that asks, is the patient black or is the patient not black? With really very little scientific evidence to have that there. There are differences in the way that we assess kidney function and pulmonary functions, which have old legacy values in them related to African Americans that may adversely affect the care that people receive. Also, there's just a tremendous inequitable distribution of resources in medicine. And a lot of this goes right along with the other systemic racism that we see in our society in so many different ways. There are fewer medical providers where minorities live. There are very significantly lower rates of insured individuals in minority populations. And therefore, there's also lower reimbursement for physicians and mid-levels to care for patients in minority categories. There are lower salaries at safety net organizations that typically serve a lot of minority communities, like community health centers, rural health centers, and public health departments, so that it's hard to keep physicians in these places and have consistency for people. And there's really not any allowance in the way that medical care is set up in this country for special needs that various minority populations have. For instance, very few offices offer very many after-hours appointments. And a lot of people don't get sick time off, and they can't take time off for work because they won't get paid, and then a lot of other bad things will happen. And then there's too often not enough language and culturally appropriate care available. So even just in the last 24 years, there's a tremendous amount of evidence of ongoing racism in medicine.
Thank you, Dr. Maynard. You've certainly given us quite a bit of data for us to kind of digest. It's quite alarming when you hear all the numbers, really, and all of the data being shared. Dr. Cohen, what would your context be relevant to how you or maybe even currently witnessing racism within the healthcare system?
Thank you for that question, Dr. Wells. Let me set the tone. I am a product of segregated education. In high school, I took a job as a busboy in a restaurant. And there was no place in the restaurant, well, let me say it this way, that they were not accepting people of color to be served in the restaurant. Mm-hmm. But I could work as a busboy. And most of us were people of color working as the busboys. And a customer got upset, and I don't know exactly what was going on, but he assaulted one of the busboys, not me, but another one, and knocked the teeth out. And the ambulance was called to come to provide emergency services. And when they arrived and saw the individual was black, they refused to treat. And they were white individuals in this situation. And let me go further. In order to reach my goal is to become a dentist, I was in the education setting was with an integrated situation in the colleges. And this was a primarily white college. I was taking a course there, and the only black person in class, and this is in the early 60s. And we were all studying to become medical professionals. And the biochemist looked at me, he is the professor. You're not going to be successful, so I'm not going to require the same criteria that I require for my other students in this class. But I'm going to pass you, but you don't have to meet the standards that the other students do. because I don't think you'll be able to even write a prescription. And he said that to me, and that was discouraging. But I was accepted at Howard University as well as some other colleges, and I elected to go to Howard University because it was a black school, and received my degree. But let me just say this, racism bleeds into every aspect of our lives. It's not only in healthcare. As a dentist in Smithfield, I was taken back when I applied for a loan and was refused a loan to establish practice here in Smithfield because of skin color. But I was blessed, was able to open the practice along with my associate, Dr. Willard Smith. It was a slow process. We had to pay for what we acquired, COD. And would you believe that the suppliers would send us something that is out of date? Or they would send supplies that were expired? And I can go on and on with instances that we incurred in this as a provider. But what is also interesting, Dr. Maynard mentioned the term implicit bias. This is something that we take for granted when we're providing care. And God blessed me to receive patients in the dental profession. My practice was made up of 50% white, if you may, and 50% black. My black patients did not want to wait in the same waiting room with the white patients. And the white patients had the same feelings. They did not want to be in the same waiting area. So we had to schedule patients in categories. We schedule our white patients at a specific time of the day, and then we would schedule my black patients at another time. And there's so much I could tell you about practicing as a minority. My last name is Cohen. I had an associate in my office, and I worked with 3 different dentists in my lifetime, and they had common names like Smith and Woods. However, I am the senior dentist, so we would schedule patients of the white persuasion, and they would come in, and my staff would seat them, and I would go in to provide treatment. I'd say, "Good evening, how are you?" And they would look at me, and the comment was, "We're not here to see you. You're Dr. Smith. We're here to see Dr. Cohen." Okay. And you all know the name Cohen, and it's an inherited name. I'm a junior, and I wanted to get that junior on my bio because many times I get the question, "How did you get that name?" Well, notorious black people get their names from their slave masters. But my patients, when they realize I am Dr. Cohen and I will provide the services, and I was able to win them over, and they would come back for future care. But there's so much that I could tell you, trying to schedule patients. When you schedule patients, and if I needed to refer that patient, we ran into difficulty when most of my patients that I saw had third party, such as Medicaid. And Medicaid don't pay like insurance patients would. And if you're a cash paying, you can pretty much write off some of the costs. But Medicaid patients, the majority of my patients, Medicaid patients, trying to schedule them with a specialist like an oral surgeon or a pediodontist or periodontist. And if you would not indicate how they're going to pay, there are about 3 or 4 methods by which you pay with a credit card, insurance, Medicaid, Medicare, and cash. The first question when we're scheduling the patients, how are they going to pay? If I say Medicaid, we don't have any openings. Or it'll be 3 months before you can get an appointment. And that's my experience, and I could give you many, many more, but time would not allow it.
Yes, thank you. Thank you, Dr. Cohen. We do have 3 questions, but Dr. Pearson, let you address this question as well. What evidence of racism in the current health care system have you seen?
Thank you. I'll be brief because I believe our panelists have talked about much of what's been seen and what we're seeing in our healthcare system. I can speak from the perspective as a Black woman practicing medicine here in Johnston County, here in North Carolina. And so I can tell you I have that similar experience of walking into a room, what people see is a Black woman. They do not see a Black physician or a Black professional. They see a Black woman. And so there's that bias or that assumption that I am someone else and not who I am. Usually we can overcome that, but people come, just as you said, with their own biases, just as we have our biases. I mean, we all come from where we come from and have our own experiences. So being here in Johnston County, and I believe everybody here knows our county is predominantly white. We have 70% white, maybe 16% African American or Black here. I've seen lots of different situations where not just providers have exhibited implicit bias, but we have patients who have their implicit bias. So I see patients who are concerned, rightfully so, about trust. They don't have trust in their provider. Some of that is due to some of the ways they've been treated in the past. Some of that is due to questions that they get asked. We talk about the guidelines. You talked about guidelines. Guidelines lead us as professionals to have more biases when we treat people. So a lot of it is building trust, trying to build trust, and overcoming those biases.
Thank you. I'll stay with you, Dr. Pearson, for the next question. Black Americans die at about 2.4 times the rate of white Americans, and Black Americans have higher rates of cancer, chronic pain, diabetes, infant mortality, and death in childbirth. Black children report higher levels of stress. While these racial disparities have been studied for decades, why do you think they still persist now in 2020?
I think a lot of this has to do with, we talk about health disparities. People talk about health disparities, and that's what these are. Mm-hmm. These are the results of health inequities. And, you know, we talk about equity, which is very different from equality. Equity is providing the opportunity for everyone to be healthy. And we see these disparities continue because everybody does not have the same opportunities. You look at the drivers of health, and many people have heard them called social determinants of health. So you look at all these drivers of health, economics, jobs that people have, housing, educational attainment, physical environment where we live, you know, is it a safe place to live? All of these things affect our health and affect how we have opportunities to improve our health. And because these things continue to be issues, everyone does not have those same opportunities. We continue to see these results which develop and end up in health disparities.
Dr. Cohen, if you would also respond to that.
Yes, thank you. The disparities that you listed in your question chronic pain, diabetes, infant mortalities, and cancer, we find that these diseases affect people of the poor working class more than it would be found in the affluent people. Now, the reason for it, and Dr. Pearson alluded to trust. And I'm going to touch on this because this is very personal to me when it comes to treatment. I can relate to a person who is black when it comes to my health care better than I can to a white person. And that's implicit. And that's the way we've been trained. I don't trust you, so I'm not going to tell you everything. I'll just tell you what I think you need to know. And that is true whether it's me as a provider or whether the patient that I'm treating is a person of color. And we have to keep that in mind when we are treating our patients. Because someone lives on Johnston Street does not mean that everybody on Johnston Street would be suffering from the same diseases. Every person needs to be evaluated on their merit. Now, majority of my patients will come in with compromising health issues, diabetes, as I said, cancer, and many times it's uncontrolled or untreated because they don't know it, but they don't get the appointments with the healthcare providers. There are all kinds of barriers up there. Transportation is the biggest. I don't have anybody to take care of my children while I go to the doctor. Specialists is not that easily located in Johnston County. They have to travel to Raleigh sometime to receive the care that is needed because there's no specialist in Johnston County or within the next 50 miles. And Wake County is, we refer a lot of patients into Wake County. And
So much of it really is societal.
yeah,
And plays just as much as a bigger role of anything that may be relevant to just the overall healthcare itself, but the societal things that come along with that. And I know we face that in education too, that many of our students who are marginalized by not having transportation, it makes it difficult for them to be able to receive the kind of instruction they need. So I see what you're saying relevant to that. Mr. Nelson, how would you respond to that?
I recently read an article by that states that a Dr. Benjamin George of the American Public Health Association stated very plainly that these disparities that we talked about are specifically due to racism. But he further says that socioeconomic status doesn't protect African Americans from the stark realities mentioned in the premise of the question. As a result, statistics point up to the disparities that some states have declared racism a healthcare, public care crisis. And I think if North Carolina looks at that as a way to address it, that we'd be in better shape than we are today, as a matter of fact. It's about naming the problem. It's about identifying what it is, and then we can seek solutions.
Thank you. All right, if you're watching on Facebook Live, you can submit questions. We're gonna try to leave a little bit of time for questions this evening. We'll move on to our next one, and Dr. Maynard, we'll let you kick this one off. Why do you think about the statement, coronavirus does not discriminate? How is that true? How might it be misleading? And how has it played out in Johnston County?
Well, clearly from the point of view of the virus, it doesn't care whose nose it lands in. But in North Carolina, Hispanic folks make up only 9% of the population, but 44% of the cases. And African Americans make up 21% of the population and 33% of the deaths. So what I think happens is that the pandemic highlights the inequalities that are there already. A lot of the patients I take care of are Hispanic, including a lot of migrant farm workers. And the biggest trouble for them, I think, is avoiding the infection because of the situations they have in their lives. Social distancing is extremely difficult for them. And housing, there are a lot of people who live in small homes with multi-generational families, so it's very crowded. In the migrant camps, several men live in the same room, and up to 15 people can share a bathroom. So how much can you really distance? Transportation, if your way of going to work is getting on an old school bus with 20 other people, there's not a lot of distancing there. It's impossible for people to stock up weeks and weeks worth of food and supplies because they can't afford to do that. So they have to keep going out and getting exposed in the community. Also, a lot of them have high-risk jobs. People work in meat processing plants, which have had a tremendous number of outbreaks. You can't clean someone's house remotely. You can't be a daycare worker or a certified nurse assistant and work behind plexiglass. You can't lay brick, you can't build a house, you can't pick vegetables on Zoom. So they have to go and be exposed, and also typically they don't have sick time off, which means that often people are tempted to work sick because they can't afford not to, and that increases the spread as well. And then when people are infected, they have more trouble fighting the illness. So people with pre-existing sicknesses, diabetes and hypertension are more common in Hispanic and African American folks. Asthma is much more common in African American folks. And people who have those illnesses are much more likely to die if they get COVID-19. Also, a lot of these conditions are poorly controlled because people don't have insurance, they don't have access to health care, they may have trouble getting tested. And some folks, like a lot of the farm workers I take care of, they may not have any support if they get sick. So they're kind of on their own and they can have worse outcomes in that way too.
Thank you. Dr. Cohen, what would your response be to that question?
Let me just say this up front. Economics is what drives racism. If you have money, sometimes you can escape some of the barriers that comes with racism. But COVID-19 does not discriminate. People do. And the people that generate policies, starting with the General Assembly, they create policies and policies for Medicaid. And then we put people who are not trained in health care in charge of dispensing those services. And my example, what I want to say to that is this. I can request a specific service, and it can go to the insurance company, and Medicaid is what I have more experience with. I am recommending a partial for an individual who, replacing teeth is necessary for the health and well-being, welfare of the patient. But the individual who receives the request to determine, to give an approval, they look at it and say, how old is this individual? And when the last time they had this procedure done? And what happened to it? And if I answer the question as what happened to it, it was in the pocket and he lost it. Well, we're not going to approve it because he's not going to wear it anyway. And that's what we're up against when it comes to, when I say, when you ask, does COVID-19 discriminate? No, people do. And it's by policy. Policies, and we don't have people of color sitting at the table that make those policies.
Thank you. Dr. Pearson?
So as Dr. Maynard mentioned, sorry about that. The coronavirus is a virus. It doesn't observe zip codes, doesn't observe county lines, state lines, et cetera. So It is just a virus that can spread to anyone. But what this pandemic, I think, has revealed is that there are people, again, who don't have equitable opportunities to be able to avoid the virus. So just as we talked about, many of the cases that we're seeing are people who are frontline workers. So those are people who can't stay home and work from home or telework. They don't have the opportunity to do that. They won't get paid. And it's them, and then it affects their family members. So it spreads to them, their children, their families, and they don't have a choice. They can't avoid the virus. So it doesn't discriminate, but what it does is it shines a light on the gaps and the problems that we have in our society.
Thank you. Just a reminder, if you have any questions, you can post them on Facebook Live. This is our final question, and we will take those questions if we have a time permitting. Last question, are there solutions you would propose to address institutional racism, particularly unconscious healthcare provider bias? Mr. Nelson?
In my opinion, one obvious solution is to offer a living wage to our frontline healthcare workers. That is from group home staff to mid-level administrative staff as well. Such a program attracts quality staff and serves to keep them as well. Too often, caregivers at frontline and mid-level administrative positions are moving from one agency to another and are seeking the best salary, the best benefits available to them. And so this promotes, at times, high staff turnover rates. That means a new staff person is coming to take care of people in care at nursing homes, et cetera. And the training gap occurs when new staff are brought in, and it takes a while to bring them up to speed as far as client rights and cultural sensitivities that we should pay attention to when caring for someone of a different race. I think that with addressing the living wage in particular, that we can solve some of the unconscious healthcare provider bias by way of training and keeping people in those positions.
Thank you, Mr. Nelson.
Thank you.
Dr. Maynard?
So I would say if we agree that Black and brown lives matter, it's incumbent on us to do something, because all of this can't continue. It doesn't make any sense. Clearly, some different training is needed for the people who are currently in medicine right now or currently in training. And one type of training that I think might be very helpful would be some cultural competency training. There's also an organization that does training, one part of which is called the groundwater training, the Racial Equities Institute. And I had the privilege of going through one of those sessions, and it was very helpful to me. I really think that kind of training would be very eye-opening for faculty in medical schools, for the students, and for providers who are out in the community. And you know, for the opioid epidemic, a lot of new training has been required of physicians who are in practice, so there's no reason that couldn't happen around this issue too, which I would argue is actually a bigger issue overall. I think we definitely have to make sure that we're recognizing the problem, and some people have even proposed coming up with a new diagnosis with an ICD-10 code, which is the way we code different medical problems that people have, and it would cover people who are suffering the effects of chronic racism. So I think that would be an interesting thing. The most important thing is to build for the future. Clearly, we've got to have more minorities in medicine. So I think what we can do right now is support African American and Hispanic children who may have an interest in medicine while they're young, even while they're in elementary school and high school. You know, they need to meet people in the community who are doing these jobs and have mentors. We can definitely have formal programs for minority college students so that they can get some relevant experience, which would also help them when they apply to medical schools. And clearly, we've got to increase the proportion of African American students in medical schools, even if that means that we need to just increase the size of medical school classes. We have a huge problem with not having enough primary care doctors throughout the country. This might be one way to help solve both of those problems. And then we've also got to turn around and support those who are doing the work. So we need better reimbursement for those who are taking care of underserved folks, because it's harder. If you have a patient who has 10 medical problems and hasn't gotten care, you know, in several years, that's much harder than taking care of someone who has just blood pressure and they've been seeing a doctor continuously for years. And I think better support for addressing the socioeconomic determinants of health, which we've talked about.
Thank you. We have a couple of questions that have come to us from Facebook Live. And Mr. Nelson, I think you touched on, as well as Dr. Cohen, about the policy. What do you think we need to do to ensure that Black and minority residents of Johnston County are given the opportunity to bring their unique perspective to policy making within the healthcare system? Any of you that would like to take it, that?
Yes, I will respond to that. To be in a position to interpret regulation, to establish policy, we as minorities need a seat at the table. And I'm not sure that is true in Johnston County because, number one, I don't see that many healthcare professionals, and I don't see that they're being recruited. When I run into individuals that are attempting to locate the professional people, they're inquiring about the atmosphere in Johnston County because Johnston County has a lot of history that is racist. And just to identify one entity that I've run into is the history about the KKK sign that was exhibited on 70 coming into Smithfield. So when I'm in situations where I'm trying to recruit an individual here, there's that negative tone that I receive, and therefore it is very difficult. That be in any profession, any Black professionals, it's difficult to recruit them to Johnston County because of the history.
Thank you. Dr. Pearson, I'll turn this one over to you. Are you aware of any initiatives in Johnston County that address the issues of discrimination within the healthcare settings?
There are multiple different programs and strategies that we're using at Public Health and with our hospital to try to focus on some of the health disparities, those people who are most affected, for example, by cancer or heart disease. And trying to work with our faith community, for example, and those in our community, providing programs to those in our community so we can get more people at the table and get input from them. I think going back to your other question, when you're talking about policies, we have to get people involved.
Mm-hmm.
And if you care about what's happening, I think you have to show up. Come to commissioners' meetings, come to building code meetings, go wherever the leadership is, and provide your input. You have a voice. Use your voice to say the things that you feel like we need to be doing here in our county. Coming from one person, or even me, it's very different than coming from someone in our community. Someone that you have elected to be somewhere, you're their constituent, but I think people have to get involved. If you care, then you need to step up and say how you feel and what needs to be done.
Wonderful. Thank you so much. Thank you, panelists. Dr. Cohen, thank you so much. Mr. Nelson, Dr. Maynard, and Dr. Pearson, thank you for being with us this evening. And thank you for joining us for the Right to Live, Reexamining Racism, sponsored by our Heritage Center here in Johnston County.
In conclusion, I would just like to say a special thank you to our panelists. This has been wonderful. There's so much information that we've got to digest now and process. I've heard some really good insights and a lot of things that we all need to think about and act upon, more importantly. So I thank you so much. I'm very thankful for our moderator, the way she kept us on schedule. I would like to say a special thank you to Denise Joyner Bennett, who really is the one who had the vision to put together this series of events to talk about these difficult subjects that we have to think about in our county, but we have to do it. And I'm glad that she had the vision to bring us together, and I'm excited about the remaining 2 events that we're going to have. Lastly, but certainly not least, I would also like to thank our social media person who is up in the peanut gallery, Lindsay Alford, who has done the Facebook Live for us for many events. And so I'm very grateful that she has provided this wonderful access to us, and also to Centenary United Methodist Church for allowing us to use this beautiful space, to Neil Davis and Warren Grimes, and my archivist, Ben Chapman. They've been working in the sound room and running the video. All these things are required to make this possible and make this successful. So thank you to everyone who's been involved and who's made this possible, and I look forward to connecting with you in another month. Same time, same place, on September the 10th. Good evening.